Wonderful. I know we're kind of running short on time and behind on our schedule, so I'm going to move on with our next session, which is the next session for the AM. We have two wonderful speakers with us discussing the idea of virtual voices, real healing, exploring the impact of VR avatars in psychotherapy. So first of all, it's my privilege to welcome on stage our first speaker, Dr. Alexander Dumais from University of Montreal. Dr. Dumais is a psychiatrist with his research focusing on the neurobiology and treatment of schizophrenia. Today he will be speaking to us about avatar therapy for psychiatric disorders. So welcome on stage.
Thank you. Thank you for inviting me to speak about the avatar therapy that I've developed around 10 years ago. I will start by saying, probably you will be disappointed. It's going to be different from Xaya. You will not fall in love with my avatar. Probably it's going to be the opposite. They are ugly, they're saying nasty things, and that's the way patients are getting better. We're not torturing the patients, we're trying to get them better. So as it was said, I'm a clinical researcher in Montreal. I'm also a psychiatrist, and my research is to bring VR for patients with psychiatric disorder, with severe psychiatric disorder, treatment-resistant psychiatric disorder. So it's the end of the line for this treatment. So we have three works that we're doing in my lab. The first one you've seen, for those that were there, my PhD student Alexandra, she presented the avatar therapy to reduce voices for treatment-resistant schizophrenia. Also, we developed a few years ago a therapy for cannabis use disorder. For those with psychotic disorders, it's a bit different than the one for schizophrenia. The concept is a bit larger, so we integrated in this study also patients with bipolar who also have a cannabis use disorder, and it's really new. We're going to start in the next few weeks. We want to improve patients with chronic depression, those that have tried many antidepressants, maybe some psychotherapy, but they're still depressed. We want to try avatar therapy with them. So schizophrenia, you will see a short video, and that's exactly what the patients are hearing every day. So don't be surprised of what you're going to hear. It's something that's not coming from patients. It's coming from what we heard from patients.
Wreck their face. Throw trash at them. They're the real piece of trash. Come on, you can do it. Go mess them up. Put them in the hospital. Go ahead. I know you want to. I know you want to do it. Go punch them in the face.
You have no control. You were never any good in school. You're dumb. You have no friends. Nobody loves you. If you disappeared, no one would notice. When was the last time you talked to your mom? Your family probably forgot you exist.
I can't believe you could do that in front of your kids. That's disgusting. You should go kill yourself. Do you even have a place on earth? You don't deserve to live. Your kids should go in foster care. They don't need a parent like you. You're such a bad mother.
Nobody, you're alone. You're sick. You're sick. That's why you have. That's why you can't do it. You can't get a job right.
Because we work with patients, we know that that's what they're living with every day. So I'm reproducing all this during the avatar therapy. During the first session, we're creating an avatar. The one that you've seen, that they're not from the patients, but it's kind of what they're building with me at the first session, where I try to understand what they're going through. And then In the second session, the exposure session, the patient is bringing me on a sheet of paper all these things that you've heard, and then I reproduce that with the patient with my voice transform. So it's really immersive. They have high anxiety at the beginning, and as you will see in the next slides, the anxiety is decreasing slowly. Is it working? The answer is yes. And it's working. I had the question this morning. Through a year, it is stable. So the auditory verbal hallucination is decreasing. D equal more than 1, it's a strong effect. So we were really happy to see that. Also, we are comparing avatar therapy to usual CBT for psychosis, especially for hallucinations, and we see that it's better on affective symptoms. Patients, they feel a lot of anxiety and anger during the therapy, but after the therapy, the anxiety is really low. So they really improve on that part. And we're really happy to see that their quality of life is improved. They are less anxious, they have less hallucinations, so it's obvious that they have a better quality of life. So as you can see here, at the beginning, the anxiety, as I said, is really high, but it's slowly decreasing, and at the 5th session, patients start to feel much better. It's still surprising for me how fast it's working. Within a few sessions, the immersion is between 5 to 15 minutes, and after it's usually once a week. So after 5 sessions, they're getting better. And also what we see is that they're more serene, they feel empowered, and the feeling of presence is high all the time because they feel it's like when they're at home and hearing the voices. So we did an analysis to understand what's happening between the avatar, me, but it's not really me because as Brennan Spiegel said, it's like a trialogue. The avatar becomes a new person in the office. So the avatar is, at the beginning, is using more confrontational techniques, and at the end, positive techniques. For patients, they're talking spontaneously about their perception of themselves, their emotional response, their belief about the schizophrenia, because most of the patients, they are coming to the therapy and say, I know my doctor thinks the aliens is not true and I have schizophrenia, but me, the aliens are talking to me. Oh, okay, that's fine. But during the therapy, they change their mind. And some of them are saying, okay, maybe I have a problem in my head. So as I said, you can see here, at the beginning, a lot of confrontational techniques, and it's decreasing. And here, it's increasing the positive techniques. So I'm trying to reinforce the patient through the mouth of the avatar, being empathetic. But sometimes, because I'm always preparing the sessions, if the patient is telling me that because we have a lot of demon, it's impossible that the demon will be empathetic to me. I won't do that. So there's sometimes I'm not doing exactly that, but usually that's what I do. For the patients, usually at the beginning they're not talking so much, as you can see here. But after a while, they're starting to have a dialogue with the avatar. It's a dialogue not with me. It's really with the avatar, and they're not psychotic. They really believe they're with them, but they know that it's a virtual reality, but they play their role. So for cannabis use disorder, because we had really good results with the avatar for reduced voices, we start to build a therapy to decrease cannabis use because it's a big problem for patients with psychotic disorder. So the avatar is representing a negative influence on the habit of the patient. And you will see what it looks like.
Stop trying to convince yourself. You know this isn't true. You are a bad mother. You're always in bed.
Your life is a failure. You never accomplished anything good for others and for yourself.
You'll see, smoking is so much fun. It's gonna improve your experiences because you won't feel them anymore.
So the patient is in a relationship, that part is with a real person, let's say the brother who's asking him to smoke cannabis with him. So the patient is learning how to say no, to say that he doesn't want to smoke because he has to go to school or he has something else to do. I'm going to show you briefly the results. My student already presented the Sabrina yesterday in the poster session. But what we've seen is that there was a 50% decrease in cannabis use in that population, and also that patient has a better quality of life. And we're currently doing a large randomized trial funded by the Canadian Institute of Health Research. To give you a taste of what it looks like in a specific patient, our first patient, I was lucky, he had a really good response. At the time of the therapy, he was 24 years old, suffering from schizophrenia. He was a really huge user. As you can see, a lot of cannabis, a lot of alcohol, a lot of cocaine every day. So his treating psychiatrist offered him a lot of therapy to help him. He refused most of them, but the VR, he said, signed like a cool, so he wanted to come. We had a really good beginning, but we had to stop after a while because there was the COVID, and he asked his treating psychiatrist, I want to continue the therapy because I think I'm going to relapse. I have strong urge to use. So we had a specific permission from the CEO, and we were able to finish the therapy. And it's a wonderful story. He finished college, and he had a job. He had only 2 relapses, but very short, and he was able to manage it, and he abstained still. So it's a really good story. So in this therapy, it's an 8-session therapy. First therapy is a case formulation, and the second one is a psychoeducation, which is not different from other therapy. But at the end of the second therapy, at the beginning I was doing it at the third, but the patients were saying, I came to do avatar therapy, and it's been 2 sessions we're not doing any avatar, so they were disappointed. So I squeezed it in the second session. So we're creating avatar. And then we're really doing the avatar therapy and we're working with the cravings, the stress, the distress sessions. Again, the patient have strong negative emotion at the beginning, and it's slowly decreasing. And the positive one, like serenity, it's increasing. And their feeling of control is much higher at the end of the therapy. And finally, for chronic depression, I don't have any results to present because it's not already started. The avatar that's what we think for now, it will represent a person with whom the patient has difficulty. So, for example, we can create an avatar of a deceased spouse that causes deep loneliness and help the patient mourn that person. Or creating an avatar of a father with whom the patient has problem. He has a lot of fights that create sadness or whatever. So it's in the proof of concept phase. I know it was brief. Is there any question? I know this morning there was some. Yeah. That's a good question. Methamphetamine, maybe in the next step. There's patients having methamphetamine problems when they come to the therapy, but they have to have a problem with cannabis. So, and it has to be one of their main problem with substance. But some of them has a methamphetamine problem, and what we've seen with the pilot project, those who have a strong problem with methamphetamine, they tend to be more those who quit the therapy. So it may be harder to get good results with that population, but I'm only speculating now. Other questions? Yeah.
Have you studied the difference between a design, patient-involved design of an avatar as opposed to a avatar designed by you to see if the personalization is a major factor in this?
No, because the patient is doing his avatar.
What I'm asking is, I'm looking at the difference. Is it the patient, why the difference between a standard avatar and the one that's patient's design? Have you looked at that? A standard avatar that you could get,
A standard avatar where, no, we didn't compare that because we wanted to, from the beginning, we wanted to be personalized to the patients. So, and when I did my first trial, we had a partner patients who said, oh, I would like to have the avatar like this. He has to be, even in the place where he will appear in the virtual reality environment, he said, no, he's too high, no, he's too low. And that guy, it was the demon, he said, the demon has to look like this. And so it was already personalized from the beginning.
Good.
So we didn't compare it with, I would say, standard or what we can find in the internet. I don't think it would be as much efficient if we do that like that.
Yeah.
Because it has to be their own experience. We want the patient to have a strong feeling of presence, feeling that they're really what they're hearing or what they feel when they're smoking cannabis. It has to be a bit like what they feel and live.
Do you see the avatar changing during a process? You're doing it over 8 weeks or 12 weeks. Does the avatar change to reflect the changes in the person? Or is it standard?
And the avatar is adapting to the patient every session. We're preparing. I didn't have a lot of time today, but the first 10 to 20 minutes is to prepare the immersion. So I'm talking with the patients about how they think it will be happen inside the virtual reality. So and I'm adapting to the patient because sometimes it's exactly the opposite that happens. Some patients are saying, no, today I'm going to tell my avatar that I will continue using cannabis. It's good for me. I like to be high. And they start the avatar, and they're saying exactly the opposite. So I have to adapt. Oh, okay. No, I don't want to smoke anymore. It's finished. I'm like, okay, it's different from what we planned.
Not to prolong it, but so you're actually editing the avatar and its response during the process, during the session?
Because I'm controlling the avatar.
Good.
Or my colleagues. I'm working also with a psychologist, and he's almost a psychiatrist. He finished his residency in a few months. So we're adapting. In the future, for sure, it will be good to have AI controlling, helping, but it's hard to adapt to fast.
Thank you.
Other question? Yeah? Can you speak a bit louder?
Did you see variations for patients who were stabilized with an antipsychotic for long periods of time versus those who were maybe medication non-compliant in terms of the response?
They're supposed to be compliant. The question is, do we see the differences between those that use antipsychotics for many years compared to those maybe for a shorter time, and if they're not compliant with their medication? First of all, they have to be compliant with their medication because we need to be sure that they're treatment resistant. If they can respond to 2 milligrams of risperidone, it's okay. They don't come to the therapy, but if you tried 1, 2, and most of the patients, they've tried 5, 10 different antipsychotics for a long period of time. Most of the patients are on clozapine plus other things, plus ECT, and they've tried a lot of things when they come to our lab. Do we see a difference? For now, no, but I would still think there might be a difference because maybe the sample size is too small to find differences, but I would say maybe. But on average, patients were sick for 15 to 20 years when they come to the therapy, on average. I've seen
Wonderful. I'm
too
sorry to
much
cut you off.
questions.
We're going to get really far behind, and I know
Okay,
lunch hour is
sorry.
approaching. So thank you for that wonderful talk, Dr. Dumais. I'm sure people can find you around to ask you more questions as well.